We're going to talk about the pipeline program that we created, but I just want to share with you, by the way, an example of someone who had to suffer through what you just talked about, my son-in-law. He graduated from high school in a little tiny town up in Northern California called Arbuckle. His parents are farm workers. He didn't quite know what to do. He went to community college, not knowing exactly why. Went to Sac City. Took him 6 years to finally transfer because he really wasn't sure and he wasn't getting much feedback. Went to Sac State, was kind of drifting along there. Then met my daughter, mijita, Catalina, okay. She's a doer, and basically she just said, well, what have you ever dreamed of doing? Oh, I've always wanted to be a doctor, but I don't know, that's impossible. Why is it impossible? And he is now starting medical school at University of California, Davis in 7 weeks. So it's a social process more than anything else. And it's good that he's bilingual because I want to talk about physicians, patients, languages, and medical care. Now, you all have been hearing all these stories about folks getting angry because somebody dares to speak Spanish. In New York, that attorney, or up in Idaho, somebody spoke Spanish, so the migra pulled them over and thought they should be deported because they had the audacity to speak Spanish. So I want to clarify something about the Spanish language in this state. If we go back to the California Constitutional Convention in 1849, yeah, we heard about this in 4th grade history. What they didn't tell you is that a bunch of Latinos showed up and they helped to write the Constitución del Estado de California. Well, they also wrote a version in English, but California came in to the United States as a bilingual state, and the Constitution very explicitly stated, all laws, decrees, regulations, and provisions which from their nature require publication shall be published in English and Spanish. Spanish is not a foreign language in the state of California. I don't care what people in Orange County say. It's our language.
Well, the street names are in Spanish.
Horribly mispronounced. Have you ever heard somebody call it La Cienega Avenue? Cienega, go figure. Okay. But as we're looking at the effects of language, it turns out when you have a patient population with limited English proficiency, this really affects a lot of their health. For example, their health status. They don't get the messages about vaccination, about smoking, about exercise, everything else. Access to health care. For those of you that are lucky enough to have health insurance, you know how hard it is to navigate health insurance? Well, suppose you're not so good in English. Which is why a lot of immigrant parents ask their 8-year-old kids to please navigate this health insurance. And, oh, you've done that, good, now we want to buy a house, can you help us do the mortgage? So access to care, making the appointments, etc. Simple things, but if you're limited English proficiency, these can be barriers. Health outcomes, for Pete's sake. Did you understand this is 2 pills every day, not 1 pill every 2 days? And that can make a big difference. And of course, patient safety, just understanding limitations of medications, etc. So limited English proficiency can create a number of situations in medical care that you would think, want to avoid. So we have been looking at what's the matchup in California between physicians who speak a language and the patients that speak that same language. So we've noticed that ever since 1980 to 2015, there have been changes in the languages that people speak in California, just numbers. For example, if we look at people that speak English, back in 1980 there were about 17 million. By 2015 that had grown to a little over 20 million. So that basically in that 25-year period, we added about 3 million English speakers. Now they could have done that, they could have immigrated, they could have been born here, a number of ways, but we have 3 million more people speaking English in 2015 than we did in 1980. Now, let's look at Spanish. There were 3 million people that spoke Spanish in 1980. 2015, 11 million. We added 7 million people that spoke Spanish. We have 7 million more than we did back in 1980. I know people tell me, oh, Spanish is going to die out just like Italian. I say, you see that growth curve? And that's been going on since 1848? I don't think so. Then there were other languages, but you notice these two are so big, so let's magnify some of these other languages. Let's change the scale and just see, because there have been changes in other languages. Basically, what we see is tremendous growth in Chinese, Filipino, Vietnamese, Hindi, Korean, and decline in European. It used to be in 1980, French, German, and Portuguese were within the top 10 languages spoken in California. So the general trend is if people study German in high school and in college, there aren't a lot of German-speaking patients. So maybe we ought to think about what are the language requirements. Now, let's put this into context. We're going to use a ratio of, okay, this is the Rose Bowl. This is our home stadium, right? Go Bruins. By the way, UCLA, I'm proud to say, is the only campus of the University of California founded by a Latino, Reginaldo Francisco del Valle, bilingual, bicultural. That's a whole other story. Okay. So this is the stadium, and it seats 100,000 people when everybody shows up. Okay, we're playing Illinois. I think half the people came from Illinois. We tend not to go, we don't take football too seriously. Okay, what we're going to do is look, if you filled the stadium up with 100,000 people that spoke English, how many physicians in the state are there to attend to that 100,000 English-speaking people? And what have been the changes? So, here are the data. We're going to look at the change in the ratio of English-speaking physician to English-speaking population and Spanish-speaking physician to Spanish-speaking population. So first, let's look at English. Basically, back in 1980, for that stadium filled with English speakers, there were 281.6 English-speaking physicians. By 2015, that had increased significantly to 344. A fairly significant, so actually it's easier to access a physician if you speak English. Now let's look at the Spanish-speaking physician. Okay, huge increase in English from 281 to 344. Spanish-speaking, back in 1980 it was already bad, 88.1, which is about a third, almost a fourth of English-speaking, and then it went down. There are fewer Spanish-speaking physicians in 2015 per 100,000 than there were in 1980. Ooh. Now remember all the problems caused by being limited English proficiency and going to see a doctor? And it's gotten worse, not better. Decreased from 88.1 to 62.1. So let's look at different languages. Because I know people say, oh, we speak so many languages. What do they say? We speak 109 languages in California. So if we have a language program, every language gets 1/109th of the funds. I've been in grade schools that do that, okay? LAUSD does that, for example. Well, that's great, but 70% of the students speak one language and it ain't English. Oh, you get the same as everybody else. Well, as we look at MDs by language, what we notice is different languages have different representation. For example, Farsi speaking, there's 1,627 Farsi speaking physicians for 100,000 Farsi speaking patients. Hindi, 1,267. Korean, Chinese, now here's English, 344.2. So these are relatively well represented. Probably we don't need any special issues. These languages we might want to think we may have some issue here. For example, Vietnamese is underrepresented. Thai, Lao, and actually this is a number. Hmong, these other languages are kind of clumped in there, but if we take out Hmong, it's so small compared to the rest of the population, you wouldn't see it. But it's really important in certain areas like Fresno, very important. Filipino, again, that's a number of languages. We tend to think of just Tagalog, but there's also Ilocano and all these other languages. And here's Spanish. One language, spoken by 13 million people, and yet it's at the tail end. So you would think that probably we might want to do something about these language groups in terms of building up the supply of providers who speak it. Well, here is one source, and we wrote this article 4 years ago, 2014, when DACA was new, and a lot of medical schools were routinely not even interviewing applicants once they found out they were undocumented or at least had DACA because them all the same thing, right? So we wrote this basically to tell the deans of medical schools and the heads of admissions committees, actually, it's okay to admit DACA students. I'm proud to say at UCLA we have 8 DACA first and second year medical students. But more importantly, we said, these DACA students are really the ones you want, because they tend to come from these underserved communities, and they're really passionate about going back to those communities. I don't know any of them that says, well, I want to graduate medical school and become a plastic surgeon in Beverly Hills and drive a Maserati. Other medical students do that, yes. But I have to tell you, I've never heard that from DACA, or usually from these language minority groups. There's more interested in, they've lived this underservice. They want to go back and address it. In fact, we released this paper at a press conference. I don't usually do them. We felt this message was so important, we have to let the public know. And this is Yawale Balderas, who actually graduated from medical school at USC before DACA. She was just de plano undocumented and managed to graduate from medical school. She got her DACA just as she was starting her residency here at UCLA, and she was the first author. This is Miri del Rosario, who at that point was a DACA. She's still DACA, but she's now a third-year medical student. And they're part of the Pre-Health Dreamers group, because we think boy, this is the one you want. Now, let's talk about, well, who speaks Spanish? Just as an example. So here we have, for 2010, for each state, the proportion of Latino physicians that speak Spanish and non-Latino physicians that speak Spanish. Okay. And as you can tell, usually Latino physicians tend to speak Spanish and non-Latinos tend not to speak Spanish. Although this is not zero, you'll notice. Small and sometimes very important. So these issues of language, culture, etc., aren't just touchy-feely, they actually influence practice patterns. Where does one practice with whom? How? And what I want to emphasize is I'm not talking about affirmative action. What I'm talking about, what I'm looking for, and I'm on the interview committee, I interview candidates, I'm not necessarily looking for Latinos. I'm looking for people who are willing to make 2 decisions that anyone could make. Okay, the decision to learn to speak Spanish. I mean, how hard can that be? I've got a 4-year-old grandson. He speaks Spanish perfectly. Of course, we were raised in a Chinese-speaking household. He speaks Chinese perfectly, too, or Vietnamese. But okay, he speaks perfectly, I'm saying. What do you mean you can't learn Spanish? And secondly, the choice to practice in a heavily Latino, which will be, by definition, an underserved area. Anybody could make those 2 choices. Most Latino pre-meds do. Most non-Latino don't, but it doesn't mean that it's zero. Because in fact, sometimes we've had very important leaders who are not quote-unquote Latino, but who took the time to learn Spanish. Dr. Mike Wada, Takashi Wada, learned Spanish in college. And he was the medical supervisor for Chicanos Latinos for Community Medicine. They go down to Tecate every quarter. He's now over at Santa Barbara, medical director. And Dr. Patrick Dowling, who also learned Spanish as an adult working with the farm workers. He's now the founding head of family medicine here at UCLA. So anybody could make the choice. And not all Latinos necessarily make the choice to learn Spanish either, or to keep it up. So it's not an ethnic thing, it's a choice thing. And then where do you practice? So we did the survey using data from the medical board. When the medical board sends out a license, to what zip code was it sent? Was it sent to a heavily Latino zip code or not? And it turns out Latino licenses were twice as likely as non-Latino to be sent to a heavily Latino zip code. Why is this important? Let's talk about access to care in a different way. Here we have Beverly Hills. Beverly Hills has per 100,000, 2,023 MDs per 100,000. If you go to, say, a Starbucks in Beverly Hills, you sneeze, about 3 people say, here's my card, call my nurse and make an appointment. I mean, just abundant, they're all over there. You see billboards, they take out ads in the glossy magazine. Beverly Hills is 5% Latino. At night, when the nannies go home, and the jardineros go home, and the cooks go home, when all their staff goes home, then it's 5% Latino. Where do they go? Many go to Bell, just 15 miles away. Bell's 91% Latino, 19 MDs. 2023, 19. So practice patterns. These things are just affirmative action. They're not nice. They actually have to do with the delivery of high quality care to populations that are growing, but are of limited English proficiency and do not have sufficient representation in the medical profession. So there's our Latino physician shortage. So where do we intervene? Actually, let me go back to this paper. This paper is a redo of our original paper we did almost 20 years ago. First, we were actually able to put a number to the Latino physician shortage, and we projected that unless things changed, the number would get worse. And guess what? Things didn't change, and they got worse. So we're saying, see, we documented that things got worse. Something has got to be done. So when we did our first paper that was published on this in the year 2000, we thought, okay, we need to get more people willing to make those two decisions into the medical education pipeline. And guess what? They're not here at UCLA. Oh, we got a lot of pre-meds here at UCLA. And many of them they want to go out and become a plastic surgeon in Beverly Hills. That's their goal in life. That's wonderful. That doesn't help what we need. Where do these students begin? Well, back then, about 75% of Latino students that began post-secondary started in community college, as did my son-in-law. So we thought, you know what? We need to be out with them. So we created a program. We started at Cerritos College. Because the community college was the key point. I mean, I'd love to get into the high schools and grade schools. For a lot of reasons we can't, but community colleges, we can. Because this issue of the language shortage is not going to be solved without, because who is more proficient in those languages that are underrepresented? Where do they start? Well, they don't start here at UCLA. They have to be really good in English. Okay, so they go to community college, and then the vast majority go on to state college. So we created MEDPEP. In Spanish, the acronym stands for Médicos, Enfermeros y Dentistas para el Pueblo. And in English, Medical Professional Education Preparation. See, here's the thing on acronyms. When they go one way, like HIV in English, in Spanish it goes the other way, VIH, VIH. Okay, and usually they just reversed. I wanted one acronym that would be the same, so that we translated it differently in English and Spanish. But the whole point is, we want to build on what we consider that learning, particularly if you want to go into graduate health education, is a social experience. We tell the kids, do not attempt this alone. So we put together a group. Here at UCLA for 50 years, we've had this group, Chicanos Latinos for Community Medicine. Up north, a similar group called CHE, Chicanos Latinos for Health and Education. Big group, and they make learning a social experience. They have study hall together, they have exam files, they go to Tecate, they do health fairs, they do all kinds of stuff. But it's social. You learn better in a group than you do individually. This is Seda Greenwood, whose place I'm taking today, but Seda just came back from maternity leave Wednesday, but she had to take her baby to the doctor this morning, woke up not doing so well. So okay. On her 4th day back from maternity leave, how could we say, no, you have to be here? So I'm here instead of Seda. And this is our poster from last year's conference, Engaged Student, Engaged Communities. And what we do with MEDPEP is we create a social learning environment. We have mentors. Every student links in with a mentor. We bring in study skills development. Because these are folks going through STEM, and it's not that difficult. You just got to be organized. The whole thing, you got to be organized. We do workshops in Spanish for the parents who often want to know, why is Mijita at the library at midnight? Must be up to no good. No, Mijita's got a final in organic chemistry tomorrow. That's why. So we work with the parents who, once they understand, really are very supportive. We take them to various conferences, some here, SC, Stanford, UC Davis, etc. I teach one undergraduate course per year. Because at the medical school we don't have undergraduate courses, so I teach it jointly with Chicano Studies and Public Health. It's on Latino health, And we have created a lower division community college version that we give in MEDPEP, and some community colleges like ELAC and Cerritos actually teach it as an articulated course, and I'd love to do that with any other campus that wants to do that. And we do leadership development because we've learned this most important thing, not only to learn to navigate, but because most of the students in MEDPEP, and it's not all Latino, by the way. We get a wide variety of people who basically want social justice, and they want to practice a social justice framework. I'd say maybe 60% of the students are quote-unquote Latino, but that's not important. The important part is social justice, wanting to make those two decisions, go out and work in an underserved area, and that will require leadership for writing statement. To get into medical school, you'll have to use your leadership to write your statement, for get a good residency, to get a fellowship, to do grants. So let's start very early on. So this is our pipeline, because what we want to do is to eventually affect this. Have better patient outcomes, better patient safety. That's why we chose to work arm in arm with where these students start, which is in community colleges, and increasingly now onto the Cal States. So we've opened up the program for Cal States as well, so we can continue this type of learning experience. There. Time for questions, thoughts, comments? Yes?
I have a question with regards to do you think that there's somewhat of a fear on the students who, let's say the ones who want to go to Beverly Hills and work, that they're racking up this huge debt, and
Usually the ones that go to Beverly Hills don't have to worry about it. About half of any given year's medical students, their parents are already physicians. And quite frankly, they don't have to worry. Now, my son-in-law, his parents are farm workers. He is going to be taking on a lot of debt, and he wants to work with farm workers. So it actually kind of goes the other way around. The ones who want to most go out and serve underserved patients are probably going to be incurring the largest debt load, but there are ways around it too. By the way, he got a $100,000 scholarship. So I tell students, don't worry about that. We'll figure this out when the time comes. We'll figure it out. There are programs, and we can plug them in. But that's why we need these social networks. So we'll never let fear or debt stop anyone. If they're stopping someone, have them come to talk with us. Yes, young lady.
What do you feel actions that you've taken, from the board to decide which students go to medical school, or some level along the educational pathway where to encourage students to maybe make that choice to take a second language or to take Spanish, so that way we can encourage students and make it almost a reward practice thing, so that more students will learn Spanish and more students will go into the medical field with that knowledge kind of already.
We would hope so, and it doesn't have to just be Spanish, by there are other underrepresented. I mean, like Hmong. I think there are 6 Hmong-speaking physicians in the entire state of California. So yeah, it's not only Spanish, but we do need to ensure a better ability. The former dean of education at UCLA, he just retired 2 years. For 20 years, he kept saying we should put speaking Spanish as one of the requirements for entry to UCLA, but the rest of the faculty didn't agree with him. Then he retired. But I think we need to understand, particularly as, don't get me talking about healthcare reform, because we'll be here until Wednesday afternoon. But things are changing. Now we're trying to teach students and residents how to do patient-centered care and have patients involved in the decisions, because ultimately as we move towards chronic disease, heart, cancer, stroke, as providers, we can only do so much. The rest depends upon what they do with 90% of their lives not in a doctor's room, how they move, whom they associate with, what they eat, what they ingest, smoke or don't smoke, etc. That's their choice. And if all we do is say, shouldn't do it, that's not going to help. We need to work together. That's patient-centered care. And how can you do that if you can't understand one another? That's the end.
I think the focus is on MDs. How about I know there's nurses or technicians.
Okay, to make a long story short, nurses looks very similar to physicians. Dentistry is so bad that it makes the physician shortage look good. There have been years when there were zero Latino graduates in the entire state, all dental schools. And in a good year, maybe a half a dozen. So, it's so bad, it makes the physician shortage look good. So this goes all the way through, by the way, and we deal with it all. Not only medicine And it's all particularly graduate health education. So with that, thank you very much. And if you have any questions, if you want to link up and join our MEDPEP program, please contact me.